So yeah, my name's Heather Meyer. Whoops, and I don't know if I have a clicker. I am a registered nurse, and my clinical background has been in surgical, cardiovascular, ICU, and ED. And ED was actually the area that triggered my interest in risk management. We had a case basically at 3 o'clock in the middle of the night, called in from the ambulance, and basically said, we have a 38-year-old female that was at your facility earlier in the day, hyperventilating. Bring her into a room. Sure enough, she's hyperventilating, getting her undressed. Basically, a demarcation line, full PE, physician. We take her to a CT room, PE, and basically had to transfer to another hospital for, needed basically to go on bypass to help through that. Wasn't until, obviously, way many months later, and all of a sudden I'm sitting in a room with an attorney and the risk manager wanting to know about that night. So that kind of triggered my interest. And we'll go into later as diagnostic is kind of one of the main things that you'll see in malpractice as causation. What would it be without a disclaimer? I am not a legal attorney, so I'm not going to give you any legal advice here, but that's my disclaimer. So again, malpractice, I'll always have to give a disclaimer. Today I want to talk about the drivers of claims, kind of go walk through the medical factors that lead to malpractice outcomes, and then talk about the Utah candor law. That's a new thing that helps mitigate, hopefully, malpractice claims in general. So when we look at top drivers of medical malpractice claims, you'll see here that overall, diagnostic is basically the highest cost, followed by medical and then medication errors. Frequency, however, is medical, diagnostic, and surgical. And if you think about medicine as a whole, it's made logical. As providers yourself, medical treatment and diagnosis is the primary. You might hear, though, that ED, OB, and OR are the top drivers. And if you think about in a hospital setting, those are the 3 units that obviously you're going to see those because you actually have hospital staff that are also contributing to those areas of claims. Again, diagnostic is the first one in the cost and the occurrences, and that's due for the high cost is because of the severity that's involved, and most of the time it's because of the 3 areas. It's either delayed, missed, or incorrect diagnosis. When we break down into looking at the diagnostic errors, you're going to see 69% are usually due to an assessment failure, and underlying that is due to cognitive biases, failure to rule out all of the factors to the other differentials that may be looked at. Data entry, we look at basically the indications for those tests are not being communicated clearly, so that when a radiologist reads it or that the causation might not be there. And then we also identify 26% when a primary care physician doesn't involve a radiologist or they read it themselves like in the ED, you're going to see a 26% increase in a failure rate from that. So if you're looking at a complex injury, we highly recommend that you get a radiologist involved in that read to help lessen it because of the fractures that can be missed by the underlying injury. Follow-up and coordination, 52% of that is in that phase of it. When you see these top misdiagnosis, cancer, vascular infection, patient communication and documentation in the medical record is usually on cancer. People hear what they want to hear as to my cancer is good or I need to follow up and they're not following the treatment plan is what we see in those type of things, or just a misdiagnosis altogether of cancer. Infection, to be honest with you, those are like delayed diagnosis and infection and treatment of infections. I'm wrong. Treatment overall and medication can be also another line indicator. Medical treatment, number 2 in cost, number 1 in occurrence. Overall, when you look at medical treatment, it's because of medical management related to improper treatment for the overall condition. And when we dig down into those reasons, technical skills and clinical judgment, and usually those are from basically patient assessment issues or wrong assumptions within that assessment area. And usually that, again, kind of comes from cognitive biases that are aligned within our assessment processes. And then your communication breakdown and the patient behavior related are pretty much in with the compliance of the patient treatment plan. Medication kind of really goes back into medication interactions or the overall polypharmacy of the causes of the medical decline are not caught or thought about medication interactions or the overall long-term effects of medication. I don't know, anyone here read the book Dreamland? It was over the opioid crisis. What's interesting about that is one little statement within the medical research on the opioid was taken out of context and created the whole pharmacological use of pushing prescription drug to the physicians, and that's how it kind of triggered. So it's an interesting book. I'd highly recommend reading it. When you look at the medication effects, top contributing factors, we still see a lot of errors in the selection and management of medication. And what you're going to see with electronic medical records, it moves and people are not paying attention. It'll click on the wrong one accidentally. So it feeds into the wrong error of the selection of dosage or the wrong medication actually. Communication breakdown with the patient's family. Again, you're going to see with the electronic medical record, unfortunately, physician or whoever will communicate what they want the patient to do, but the discharge instructions will have a little bit different, which creates confusion, and there's no clarifying from the patients, and so there's confusion there. Patient assessment issues, it really kind of comes back to not all information looked at. And then communication breakdowns, kind of the handoffs from providers to providers, or from front office staff to the physician, actually, again, for medications, getting prescribed or needing them to come in. Surgical, while it might be fourth in cost and overall, number 3 in occurrence, ortho is the number 1 factor with about half of all the claims that you'll see in surgical areas, followed by general surgery. And usually you're going to see improper management related to infection, pain management, or the malunion of fractures, and then either nerve or organ damage within that. And really it's basically the delay diagnosis of either bleeding and stuff like that within the general surgery population. And unfortunately, when you're looking at malpractice documentation in the surgical or procedural component is the number 1, and when I say it's too bad, it's because that's your number 1 defense, obviously, is documentation in any malpractice case. So it could be easily controlled. Patient behavior factors, dissatisfaction, kind of goes back into that informed consent process. Selection of procedure or the actual patient assessment. Again, documentation, why did you select it? Telling the story as to what you'd seen, felt, and your determination will go a long way in defending your practice. Okay, now I'm going to kind of transfer from the claims element into more of the malpractice side of things. So what I want to say is how many people have been sued, and no one wants to raise their hand up, right? Because it's like an embarrassment as to we want to keep it kind of to ourselves. But years ago, people, 2016, they said 36% of physicians have been sued. Nowadays, I'm going to be honest with you, it's probably 50%. And I don't think physicians realize how often physicians are being named in lawsuits. But there are 4 elements that must be proven. And it's really not black and white when you look at the duty of care. Think of your curbside consults or your hallway discussions with another provider. So many times if you stop and are asked questions, you can actually be pulled in. And the more details you're asked about that case, you can actually be called into. Number one thing in a plaintiff's journey, like, who did you all talk to about this care that you rendered? So I always recommend is this a formal consult? Make sure that you have that kind of in your mind of, they asked me, yes, but I also asked, was it a formal consult? And they said no. Then he kind of goes into the standard of care. I hear that term a lot used, standard of care. Technically, standard of care is a legal term, but legal care obviously has to be defined in the medical malpractice world by an expert. So you have to be either similarly qualified to manage the same condition under the same circumstances. And this is where I will also see discrepancies, because people want to be an expert in a rural setting when they're doing more of a metro area. And again, you have to be really judgmental as to if you see an expert, if you're in that being sued, also look at it and say, hey, they don't practice in this, here's their background. So you really want to say they might be an infection doctor, but they're not a surgical doctor. So really cross-examine. I always say a provider that's also judging your care, because you're the expert also in that care. So challenge the experts that are also giving expert opinion on your care if you're ever brought into a malpractice claim. And then most of the time, obviously you have to have the causation of the injury, because if you don't have damages, you don't have a case. And this is where the standard of care and the causation is the most time intensive and costly of a malpractice. And this is where a lot of physicians get exhausted by the whole process, because the whole case can either take from 18 months, and we've had some cases up to 10 years, and this is where you get totally exhausted going through the process. And, but again, there is no damage, there is no case. And so if you get a complaint, I always say, walk it through in your mind. Are there truly damages? Is there a negative outcome? And we'll talk about a little bit later about how, if there are, quote, damages, harm, how you could possibly use the Utah Hander law to help you through that process. And then what do plaintiff attorneys look for? There's certain elements, but another way that you can kind of look at your case is take the medical record and review it. And what does the story, the whole care, tell? If you read through the whole medical record, what would the story tell? Does it leave you with any open questions? Do you have any things that, like, answers that aren't answered? Are you thinking about, well, what about this? What about that? Is it another diagnosis? If you have questions or you're thinking of another, that's exactly what a plaintiff's attorney is going to say, and they're going to come up with their own conclusions. So again, another way to say, if I was another physician looking at this, would I have any questions? Would I doubt the care that was rendered? Now, when we look at claims analysis, there's so many things that you would think it would be just the medicine, the case review, but you know, you can have, unfortunately, if your practice or hospital that you're working with has a policy and procedure and that's not followed, you're going to violate your own practices. Therefore, you are guilty of malpractice if you set up a practice. So that's why it's also important when you set up policies and procedures not to pigeonhole yourself into a practice that you can't do 100% of the time. So always write practices of giving yourself a little maneuver in those. Don't do it black and white. Venue, location of a malpractice claim has a huge impact, again, because of the jury selection, the demographic of those juries, how they view healthcare providers is huge. This is changing daily. Basically, corporations are looking worse. So if you work for a big corporation, overall, just the whole venue and demographics of that jury pool can make an outcome change. Again, yourself as a physician and the plaintiffs as a witness. Basically, I hate to say this, but it's the empathy factor and how well you present, quote, on stage, because the trial is going to be based on how well you present yourself on stage in a trial. Medical records and audits, again, is your documentation. Do you have gaps? Is it complete? Does it tell this true story? Medical records now, they have time of how long you were on a page. Did you bypass an alert? Oh, you only had 30 seconds on that or whatever, reading the history. How did you come to a conclusion so quick to know that? So unfortunately, the plaintiff's attorney uses a lot of the data to also give you kind of a story that you weren't doing your best. Laws in the state are another factor. Plaintiff's attorney versus a defense attorney. They also kind of are on stage, if you will, and the juries are judging them of how well they present their case. And unfortunately, judges also, we look at the judges, how their experience is. That's going to be a huge factor also if they're pro-defense, pro-plaintiffs. And unfortunately, politics are starting to influence the judges' opinions. And then over again, judges and sympathy overall, how that plays out in a jury. OB cases, while they might be low frequency, they do have a high payout, usually related to the emotional, subjective, humanizing the impact that leads to high payouts on those. Anyone know how much it costs to file a lawsuit in Utah? $375, not a lot. So with that, the process, obviously, there's the pleading, so $375, they file it, $375, and earlier I think there was that pre-litigation talk, so it'll go through that, but again, not a lot of merit. And then kind of goes into the whole discovery process. And again, this is where we're talking again, the standard of care, all the time and effort and cost goes into discovery. And this is where I always say the physicians have the greatest impact on your case. You know the processes, you're the expert. Even though it does take a lot of time, get involved in your case. Be there, work with your attorneys, stay involved, stay active in it, because this is, again, your outcome. You have got a lot of input. And so if they say an expert, again, says something, read into it, look into it, give your attorney resources, tell them everything good and bad about your care. Don't be ashamed about it. Help with your defense. Early disposition in Utah, if the plaintiff owns basically compensatory damages, if they own same or more about compensatory fault, there is no damages. You win the case, so you get a defense verdict. So it kind of goes back in again, documenting that patient's response, how they're following up, not following up, that overall compliance can help you down the road, show the overall compliance with their care, if it's good or bad. And then trial, obviously, important to document all the behaviors again. Again, it's a long thing, but again, stay in it. Get some peer support, helping you through the process. You don't have to go alone. That's my biggest thing is like, it's gonna be a battle, but stick in it. It's what you pay your insurance company to do, is protect you in the long run. So we're there for you. Who's at risk? 71% of patients who sue a provider is because there's a poor relationship. So the more you can work with your patients and maintain a healthy relationship, the better off. If you display insensitivity to their concern, obviously you're gonna get a complaint. Patient needs are huge, so if they're not like feeling like you're getting the outcome, sit down and have that conversation, take time, and sometimes if you have complaints, multiple complaints, I would really suggest looking into maybe it's time to terminate that patient relationship, because if you can't satisfy the relationship, you're gonna be at higher risk of them filing a lawsuit. So get it done before there's a true harm event that settleizes. And again, more people today, which right or wrong, I'm not saying it's good or bad, but they want to be more involved in their care. So more of an authoritarian, as I know what's right for you, does not work with the younger population. Criticize others. So again, we'll see in cases like a provider will get a second opinion, like, oh, they should have done this, they didn't do that. What happens with those cases, actually, you're going to pull yourself into the lawsuit more than people realize. It's never good to basically criticize another care provider's care. And so again, talking through that, think of words you're using. You're just not helping yourself in the end. Overall, the medical malpractice industry is facing a lot of changes. The juror sentiment is actually changing again because of the public attitudes overall with litigation. If you think about how many attorneys are in the industry now, litigation is more prevalent than ever in our world. And that's kind of due to the media influence, patient empowerment, social values, medical expectations. Everyone thinks everything should be perfect now, and they want to blame something if it's not perfect in the overall. And now we have Google Doc, so too, everyone knows to be their own doctor. Public verdicts, large verdicts are publicized. Higher settlement expectations. So it used to be plaintiff's attorneys would really give a value. Now, whatever your insurance limits are, they're like, I'm not settling anything and you have to give me the insurance limit. So 1 in 3, they'll say I want $1,000, even if the case is only worth $500,000. So the higher limits you got, the higher you're going to see higher payouts. Pressure to resolve cases, we're seeing that more too because it's more about that social reputation versus the actual practice of medical science. Overall trends nationwide, the plaintiff's bar is being well funded by private funding for social justice. Obviously, we have social inflation. Reptile theory, that's basically, it's not about the case in general, about the science. It's basically, if it happened to them, it could happen to you, and you need to save.
Result in the CH problem, but it can't get the MBA here.
It could happen to anyone, and so you need to save the community so this bad doctor doesn't hurt anyone else. That's what the reptile theory is. Again, conspiracy theories, if there's missing documentation, they're hiding something, they're trying to cover things up. And then life care plans, it'll be crazy. The plaintiff's attorney will say all this care that needs to be done. Again, I think as physicians, you can look at those and go, no individual would need that. That is not medically indicated. Again, the public newspaper of this $1 million verdict. You never see victory for excellent doctor, falsely accused of medical malpractice in the newspaper, but you always see these large verdicts for the plaintiffs. And if you do see a name in the newspaper, they must be a bad doctor. So again, it's that reputation. Everyone wants to hide behind it. No one wants to see their name in the paper. So how do we combat that, truly, as a medical profession? Careful selection of the defense counsel. I know everyone might, if you've had an attorney or you hear a peer like, oh, I had this defense attorney, that is true, that's great, but every case is different and you want the best attorney that's handled that type of case. Again, like going back to those factors, who's worked against that plaintiff's attorney, who's worked with that judge. There's so many other factors involved anymore besides just the medicine. United Defense, if you got like 2 people, 2 physicians or 4, it's better to, instead of pointing fingers like, oh, well, they did this and that one did that, looking at what percentage owned. United Front together says to the whole plaintiff's things, no one's guilty, but if somebody points a finger at one provider, somebody's guilty, so who's going to be guilty? So again, United Front is way better than pointing fingers. Again, a lot of people will get tired because of the time frame it can take to get through these. So I always say is like, just stay the course. I know it's very time consuming, emotionally draining. Peer support. If your insurance company has peer support or just a peer, you can't talk about the case per se, but you can talk to your peers about who's been through it. We have peer support in our insurance program, but it's so much helpful. And if you do need to talk, just tell the attorney, I need to talk to the people involved. Get that protection, the attorney thing, but don't wear it on yourself. You don't need to do that. It's like, talk to somebody. And we talked about the whole life care plans and expert testimony. Again, I think, even if you're an expert, if you are an expert saying bad things, I think overall, remember, what we say about our practices will come back and haunt us also. We're going to be a recipient of what we give out. But really, in the end, it's not that bad overall. On average, 90% of lawsuits brought forward do receive a defense verdict. The large verdicts are on the outlier, but they are increasing, so we need to watch that because obviously that increases your premiums and overall creates a hard market, which increases physician practices going out, especially for the independent provider. Industry-wide, 5 to 7 cases are tried, and of those, still we get a strong defense verdict. One thing that's good about Utah, they passed in May of 2022. I think it was May 4th, actually, of 2022, is the candor law. And I don't know if you guys, any of you, have you used the candor or have you heard of it? Okay, so the candor law is basically an early intervention. It's an opportunity for providers to, when they have an adverse outcome, to basically act on this act. And it basically involves 4 areas. You investigate the cause of an adverse event, you communicate around the investigation, you communicate around the steps that you might take to mitigate future harm, and then you decide if you want to basically extend an offer of compensation to the individual. These are the overall components of the candor law. That is, it has to be implemented by a provider, must give written notice. It can be enacted up to 365 days after the adverse event. Also, if other providers are involved, you must give notice to those other providers that you want to implement the candor process. You have to let the patient know that they have the right to be involved in this, and those rights, that they have the right to seek legal counsel, right to file a claim still, that there is no recording of this process without mutual consent. If there is a decision to make a payment, regardless, this is the key here, is you have to do this before a patient makes a demand for compensation after an adverse event. If that is done, then there is no reporting to the National Practitioner Data Bank. They can still, even through the candor process, still file a complaint with the licensing board, so that's a different process, obviously, to your medical license. During the process, if they want to, they can terminate it. Even if they got payment, they're not signing a release of liability. But anything done within this process cannot move forward, even if they don't, into a litigation. It's all confidential. So anything, any investigation, any work that you've done, truly keep track of what everything's done. You're obviously going to work with your medical insurance provider and stuff, so you're just not going to do this on your own. But that all and everything created for the candor process is confidential. And they say it's basically 50% if you jump on an adverse event and have communication early. It is if you don't have all your facts together and you're just doing it to reduce the probability and you're not really looking at the process and stuff like that, it can actually backfire on you. So again, you've got to investigate, you got to really determine the facts of why the adverse event happened and communicate and bring that patient along. That's the overall process about candor, is to maintain that relationship and open communication with the patient, which again kind of goes back into that 71% of why patients do is because of the communication. They want to know what happened. It gives you a process to go through that instead of being concerned of I can't say anything to the patient anymore because they had the bad outcome. And I think the biggest thing is you pay insurance to help you through the process. You don't have to wait for a bad thing. So if you ever have questions on anything, always reach out to your your malpractice carrier. I'm a risk management consultant, so physicians can reach out to me before anything happens to say, hey, I've got this complaint or I'm going through this. So whoever your insurance carrier is, reach out to them proactively. And if you do have an adverse event, again, get it reported. You don't have to go alone. They're always there to support you through that process. So I thank you for your participation, and any questions? If not, thank you.